Welcome to TrulyFit.
Rick, thank you so much for joining the TrulyFit Podcast. Why don't you give my audience and listeners a little background on who it is that you are and what you do in the health and fitness industry?
Hi, Steve. Well, thanks for having me on, truly. And I am a physical therapist for about going on 30 years now. And I specialize in helping people with chronic pain issues. Not because I'm particularly interested in chronic pain, but that's what filled my schedule so much all these years. And so I think we've got a big problem about how to solve chronic pain. And that's what I ended up focusing on.
Do you have a definition of chronic pain? It doesn't need to be, let's say, in the literature, a Rick Olderman definition of chronic pain.
Yeah, well, in the literature, chronic pain is defined as any pain that lasts longer than 3 months. So I don't know who came up with that, but, I kind of think of it as any kind of pain that seems to rear its ugly head, once or twice a year or daily, for a long period of time is chronic pain. If it's something that you have to keep trying to manage, that's considered chronic pain as far as I'm concerned.
Is the reason, and I'm sure we're going to get into your ideology behind all of this, but do you consider the reason for chronic pain to be multifaceted? Meaning, is it not just a structural issue, but it's also maybe a psychological issue and a cultural issue and a sort of a day-to-day issue about people's lifestyles and things of this nature?
Yeah, well, gosh, you're heading right into one of my overall writing theories about why we have chronic pain. I've developed this 3 pillars theory. So everyone has a threshold above which they have pain. I don't care whether yours is up here, down here, it doesn't really matter. Above this threshold, you have pain. And I find that there are 3 things that are pushing us towards that threshold. One are musculoskeletal issues. Mm-hmm. One is psychological, emotional, or spiritual issues. And then the third are things that we ingest, diet issues, allergens, molds, things like that. Your pain can be a result of all 3 of those, or just one of those, or any combination of those.
And it's difficult to diagnose because of that reason. I'm not speaking for you, I'm speaking for myself. You can disagree, because what can happen sometimes is a patient can go get, let's say, imaging, and we can see something that is obviously telling of maybe some potential pain, but there could be more to the story. And we associate that, let's say, some lumbar issue with the specific pain, but it could be deeper than that, right? It could be because of their lifestyle or because of some issue that they're dealing with psychologically, meaning I could look at 10 different x-rays and they could all have the same lumbar issue, but maybe only 2 of the clients are in pain. And that is sort of telling that the pain is way deeper than just what we're seeing on imaging.
It can be. And this is the beauty of what I've been kind of digging into for these past 2.5 or so decades, is understanding the musculoskeletal component of things. And I've become very confident that if someone isn't responding to my treatment, it's because they either have some structural issue like a tear or something that hasn't been identified yet, mm-hmm. or there's an emotional or dietary issue going on. Mm-hmm. So the results that I get are so consistent. That consistency helps me arrive at those conclusions much more rapidly and confidently when they do occur.
Walk me through a patient experience in a normal circumstance compared to yours. Meaning, if I go to a regular physical therapist as opposed to Rick, what may you be doing differently than the average physical therapist?
Yeah, well, it may kind of look the same, but initially, basically what I do is, if let's say you come in with back pain. Mm-hmm. So if you come in with back pain is part of a larger system that I call the lower body system. And so I'm not sure, is this going to be video on video? Okay, so if we look at the skeleton, what we look at it for anyone who comes in with any kind of, you get the same exam if you have foot pain, knee pain, hip pain, or back pain. It doesn't matter, because it all belongs in the same system of problems. So we evaluate you from the rib cage all the way down to the foot, regardless of what kind of pain you have. I don't believe that many practitioners do that. And there are certain things that we look at in that exam that are, I feel, key to understanding the source of chronic pain. One of those is perhaps femoral anteversion and retroversion, which we can look at if you want to and talk about. But we're looking for patterns of issues that are occurring, and then physiological reasons for those patterns of issues. And I know that sounds kind of complicated, but really it's much simpler to look at things from a systems standpoint than the component training that we've received in school to try and identify and help pain.
Well, I don't envy you, because what I find difficult is, you'll see some practitioners say it's let's say the knee issue causing the foot issue. And you'll see others to say it's the foot issue causing the knee issue, right? So when there's multiple issues, let's say knee, hip, ankle, which there usually is, right? Because there's some compensation patterns and some synergistic dominance. How do you really pinpoint which is which? And do you think it's that there's practitioners who just say, hey, I'm the knee guy, so I'm gonna say this is knee related and that everything else is coming from the knee? Or do you think that you need to be targeted, like you're saying, and really just dig down and say, what is causing all of these other issues?
Yeah, so certainly there are people who just will be called the knee guy, but understanding the source of the pain, it could be all at the same time. So understanding exactly which one came first is sometimes important, but often because it's affecting the whole system, when you fix the whole system, it doesn't really matter which one is coming first. So what often happens is when you fix the whole system, the one that is the hardest to fix ends up being where the source is. And then that's when I usually get, because during my exam, I ask people, hey, you've got back pain. Do you have any other older injuries in your feet, knees, hips, things like that? And invariably people will say no, right? And then once we start solving problems and we run into, gosh, what's going on with this ankle? It's restricted and there seems to be a problem down here. Oh gosh, now that you think about it, and then they remember some old injury. So The problem is that we're not trained to think of our old history as the cause of our current pain. And that's where the disconnect is happening for a lot of people understanding what's going on.
Yeah, Rick, and I'm so glad you said that. I had this conversation a lot with some young personal trainers that I mentor, that when you fill out, let's say, a health history form, or your client does rather, or what we call a PAR-Q, a physical activity readiness questionnaire, you can't just get that form and call it a day. You have to sit down with them, go over the form, and do what my wife is a physician. She calls it the what else. You just keep asking what else, what else, what else, because inevitably there are things that they're not going to mention. For me specifically, I just had a surgery on my hand, and it's called a central slip injury. And when I went into the surgery, they had asked, have you had any other surgeries? And I had said no. I had 2 other surgeries. I just forgot them, right? You have this like natural amnesia where you want to forget that you've been through these like medical, problems in the past. And I think we really have to make sure that, because everything matters, right? Like you said, if that person did, let's say, break their ankle 10 years ago, they didn't think it was a big deal. They were healed quickly and they were younger when it happened. That doesn't mean there are not, reverberations down the road and compensation patterns from that initial injury.
Absolutely. In fact, I just had an appointment with a guy who's having chronic Achilles tendonitis, now tendinosis, is looking at almost rupturing his Achilles tendon because it's so damaged. And he had an appointment with me. He says, what is going on here? And of course, he denied having any other injuries. And then once I tested him, we found out a significant problem with his opposite leg. And I said, why is this happening? And he said, I have no idea. I said, are you telling me and he was an athlete. And I said, are you telling me you've had no injuries to this other leg? He says, okay, I broke that ankle when I was playing high school baseball, but that hasn't hurt since. I said, that's the source of the problem, right? And so we're trained to believe that because something doesn't hurt anymore, that it's not a problem anymore. But what we don't understand is that our brain creates compensation patterns to allow us to go around these little obstacles that are happening in our lives. Because our focus in life is to get from A to B. And our brain doesn't, you're saying, brain, get me from A to B. And your brain says, okay, I'll get you there, but I'm going to do these little maneuvers to help you get there. So this mental jujitsu is happening under the radar. And then only when we start to have chronic pain do we start to realize, what your brain has been doing all of these years.
Yeah. And also to someone like you, it's not complex because you know the body so well. But to the average person, they can't put 2 and 2 together, right?
No.
And even for me, I'm a corrective exercise specialist, doesn't mean much, but it took me a while through my injuries to sort of relocate what exactly happened. I had a labral tear in my hip. I elected not to get surgery, but I sort of rehabbed myself. But what I did in there is I caused some compensation patterns where my adductors on that side became very weak because I couldn't engage them. And then I ended up having to get a double inguinal hernia surgery, which was most likely because of the fact that my adductors were so weak on one side. So like, we can put the pieces together, right? I call it being an anatomical sleuth, but the average person can't. And that's why they need to go to people like Rick when they have pain, because it is, I know to you it's not complex, but to them, it's usually a layer or two deeper, and they're not going to figure it out themselves.
Correct. And frankly, Steve, I'm the last person that these people come to. They've been to tons of other people, they're personal trainers, yoga instructors, Pilates instructors. So I don't believe that this is just in my wheelhouse. I believe everyone who works with the human body and helps with movement in some way or improving the human body needs to understand really how the human body works. And I think I would love nothing more than to be put out of business and never see a chronic pain patient again and have you guys take them all, because you're the people that they're coming to first. So you should have this knowledge, I feel, and you can have it. It's not that hard. It really isn't. As one of my therapists, because when I owned my own orthopedic clinic here in Denver, I trained all of my therapists. I wouldn't let anyone work at my clinic who I didn't train. And so invariably the response I got from my therapist is, this is so much more comprehensive, yet so much simpler than what we were taught in school. And that's the way it is when you understand things from a system standpoint.
What do you think about common therapies like soft tissue work, let's say ART, NMT, sort of chiropractic methods, things of this nature, acupuncture? Is this something that you are working with in your practice? Do you think they're all sort of somewhat beneficial and somewhat not? What is your take on those?
Yeah, I think all of those things can be very beneficial. So they wouldn't be around if they weren't. So what I think is missing, though, is an understanding of why all of these conditions are happening that these people are treating. And even if they're treating them successfully and making pain go away, if things aren't looked at from a system standpoint, it's likely that pain will come back, maybe not at that exact same vertebral level or that same joint, but maybe an adjacent joint or tissue or something like that. It will come back if you're not solving the system's problem. Because ultimately, how you're using your body is the reason all of these problems are occurring. And if that isn't being addressed as a system, then it's a patch.
I imagine dealing with, and you can tell me that I'm wrong, dealing with, let's say, a weekend warrior and maybe a real athlete, like a collegiate athlete, and then just someone else who doesn't even work out at all and comes to you with chronic pain could be different given their lifestyles. Do you treat them differently, or do you not see that as a big difference? Pain is pain.
It's funny. I received a phone call from a professional athlete a little while ago, and they said, yeah. And I talked to them, and they said, well, my body is different because I'm a professional athlete. And I said, I don't think so. I said, the person who's working in an office is using their body just as much as you're using yours. It's just in a different way. So they're a professional athlete for the office. You're a professional athlete for a sport. So the body is not any different. So I look at everyone exactly the same.
Okay. But are there particular exercises maybe that you see with, let's say, athletes or, again, the weekend warriors that could be causing some issues, let's say, right? So someone goes, hey, listen, I'm involved in CrossFit on a regular basis, and these are the exercises I'm doing, as opposed to someone who's just in the office. Do you feel like you have to maybe say, hey, listen, not only do we treating the pain, but you may have to back off of certain things that you're doing in order for the body to heal?
Yeah, I'll only talk about that kind of stuff after I know that they understand why they're having pain. So I'll go through my exam, explain, and show them exactly. And we do test and retest. So let's say it hurts for you to, maybe bend over. All right. Oh, that causes my back or sciatic pain every time I do that. Okay. Now we're going to do this exercise, and we're going to do that again. And lo and behold, it's resolved now. All right. So now they understand they can link, that exercise with their pain. So at that point, they understand what's going on with their pain. And then we can talk about, okay, so let's look at your exercise program. How is that addressing this thing that we found is solving your pain? And if it's not addressing it, or if it's working against it, then I don't have to tell them, don't do that. They come to those own conclusions. And I'd rather the patient come to that conclusion, because it's their body and it's their goals, right? I can lead them there, and I can, usually most people figure it out once I show them what's going on.
Yeah, a lot of it's just the sort of Socratic method. You just keep asking the questions and then they say it out loud and they recognize themselves what they're doing. Right? I have clients who are a little bit older who, let's say, play pickleball. And for some odd reason, it's something they've been pushing towards the older seniors. And I disagree that that's not a great sport for some of these seniors. You have very quick twitch lateral movements for people who are in their 60s and 70s. It just doesn't always go well. So anyhow, they come into me with injuries all the time. And I say, well, what'd you do the last week? And they said, oh, I played pickleball. I said, oh, when'd you play pickleball? Tuesday. I said, when'd your ankle start hurting? Oh, Wednesday. I said, oh, okay. And they start to put two and two together. And,
Yeah.
But it is a big part of being a health professional is that you want them to pick up that on their own, and you have to kind of force feed them the information because they're not going to make the proper changes unless they feel like they came up with the idea in the first place.
It's a much more permanent idea when they come up with it themselves. So, I mean, let's face it, a lot of times I have to actually tell people what to do, all right? And I'll do that if I have to. But I just feel it's absorbed internally much better if they can come to those conclusions.
There seems to be a big mobility craze now, and I'm certainly someone who is all for mobility. When I work out, let's say, for me, it's the most important thing to do is to move all of my joints in every range of motion possible before I work out. And now that I'm older, I'm 38, I have to do about a 15, 20-minute warm-up before I do anything, before any exercise. It's a really long dynamic warm-up. So I'm all for mobility. But from a corrective exercise standpoint, I believe, and you could disagree, that a lot of this is strengthening that needs to happen. Let's say when someone comes in with like a lower back issue, it's because there's a lot of weakness in certain areas and they're not stable enough. It's not that they're not mobile enough. Do you disagree or agree with that? What do you think about the whole mobility craze in general?
Well, not all mobility is created equal, and some mobility is excessive and some is not. So this, I kind of mentioned femoral retroversion. So let me kind of explain femoral retroversion and anteversion in regards to mobility and how this might affect how you warm up. All right. Mm-hmm. So if we have a skeleton and we have a thigh bone, all right. Now, the shape of the thigh bone is not the same in all people. Some people's thigh bones are twisted inward. This is called femoral anteversion. And some people's thigh bones are twisted outward. And this is called femoral retroversion. So there are a lot of implications to understanding whether this is happening or not. Those people, and females tend to be more towards femoral anteversion.
With a bigger Q angle.
Pardon me?
With a bigger Q angle, correct?
Well, that's one of the things that contributes to the Q angle is the internal rotation of the thigh bone. Mm-hmm. So, and then men tend to be more retroverted or externally rotated with their thigh bones. So when this is happening, in general, the hip joint, the knee joint, and the foot joint don't like internal rotation because that increases compression, all right? But when you have a thigh bone that's already built for internal rotation, that means that you have to control that internal rotation even more than most people who don't have a thigh bone built like this, all right? So, and the thing that will control that thigh bone the most is the butt muscles, all right? So you have to make sure that your butt muscles turn on correctly at the right time during your gait pattern. That's the most common activity that we're doing with our butt muscles. So that's the most critical one. So anyway, regarding this, so if your warm-up routine is taking you into internal rotation a lot, you're going to say, oh, this is a piece of cake. I can do this all day long because you're already built biased to that. And if your routine is then trying to take you into external rotation of the hip joint and you don't have that motion, you might think, oh, I'm too tight. I've got to work that external rotation to get more external rotation on my hip joint. Well, it's not a function of soft tissue. It's a function of the shape of your thigh bone. So all you're doing is more damage, trying to get more external rotation when you don't physiologically have it. With an retroverted femur, if you try, again, external rotation, oh, I can do this all day long. This is why guys sit with their knees apart. They call it man spreading, right? And women typically sit with their knees together because of this anteversion and retroversion idea of the shapes of their thigh bones. But if that same guy with the femoral retroversion tries to get internal rotation of the hip joint and thinks it's a soft tissue restriction, well, then they're only going to be damaging the tissues in their hip joint. Because even when the knee is in a neutral position, that could be all the available internal rotation that hip joint has because of the shape of the thigh bone. And this is often where labral tears excessive arthritic changes, bursitis, all sorts of groin issues occur because of a lack of knowledge of femoral anteversion or retroversion. So from this standpoint, and so if you do try to get and make that hip go into internal rotation, it's not only going to be expressed at the hip joint, the next joint is the SI joint. Mm-hmm. So that's going to compensate for the lack of hip joint mobility. And if the SI joint is not moving, then the next joints are going to be the spine joints. And so now you're creating all of this compensation occurring through other joints because of your idea that you need all of this mobility in your hip joint so that you can have whatever some book has said, we should have this much internal rotation and this much external rotation. So this is generally how mobility works all through the body.
Could you walk me through how femoral retroversion or anteversion and a squat could hypothetically be affected by that? Meaning, if I am retroverted, how that would change maybe the positioning of my squat?
Absolutely. So this is really important. In fact, I worked with an NFL player just recently, and he came in for, let's see, what was it? It was ankle pain, but he also had hip pain and knee pain that he didn't think was as significant as his ankle pain. And this only started when he started working out when he went to his Division I school for football. And what they did is they put all these guys in the same, you're a lineman, these are the exercises you're going to do, and this is exactly how you're going to be doing it.
Yeah.
No idea of femoral retroversion or anteversion. And this is when all of his lower body pain happened, right? Once I told him about this concept, his pain of 9 years while he's playing NFL football went away in 3 days because it was a biomechanical issue, not a structural issue. It was becoming a structural issue because of the biomechanics, but it wasn't to that point yet. So to answer your question about femoral retroversion and, let's say, squatting, we all have this idea in our brain that when we stand, our feet should be pointed forward. But if you have a retroverted femur, what that means is that you are now internally rotating that hip joint to get your feet to point straight forward. And so now you're walking around with excessive internal rotation all the time. And guess what? What are the muscles that are contributing to that? The inner thigh muscles. So then you start to get tight inner thigh muscles that start to constrict the hip joint because of this idea of I've got to point my feet forward. So when we're squatting and now we're under load, we have to make sure that the feet are pointed in the direction that the thigh bone is rotated. And so if you have retroverted femurs, the feet have to be pointed out in order to align it with the shape of the thigh bone in order that the knee and the hip joints can move correctly and with full range of motion in their sockets. If that foot is pointed forward and now you're standing in relative internal rotation, your hip joint will be restricted. And so then when you go into that squat, again, the SI joint, the knee joint, the ankle joint, the back joints will all start to accommodate or compensate for that lack of mobility in the hip joint. It'll be subtle, but when you have 600 pounds on your shoulders and you're doing squats for days and years and months and whatever, that really adds up.
What is the argument, if any, with people in your industry who do the same thing as you? If you might present this to them, what would they say? Do most people agree with you? Do they disagree with you? Is this something that you sort of learned over time through your 30 years, as opposed to this was presented to you sort of academically?
This is what I've learned over my 30 years. So most people in my industry don't even look at femoral anteversion or retroversion, don't even know how to measure it. So, and if they do, they don't know how to use that in terms of biomechanics in sports that I've found. Of all of the therapists I've been training at my clinic and all of the therapists that I meet, this is new information for them because I certainly wasn't taught this in school.
I can tell you that, to me, just like one of the people that you were teaching said, although it is somewhat complex, it actually makes things more simple, right? In a way. So when I work with people, I never fight to get them in a particular squat position in which I believe biomechanically they're not meant to be in, right? It's very obvious to me to tell if this squat is, forcing somebody to be uncomfortable to the point where the biomechanics, first of all, look wrong, right? We have a sense as fitness and health professionals. I've watched literally tens of thousands of squats at this point from different people, that this doesn't look right, right? This person's feet needs to be a little bit wider than mine. That's fine. This person's toes need to be slightly pointed out. That's okay. And I think understanding that all of our bodies are built a little bit differently, especially like you said, with where the femur inserts, makes perfect sense to me. And it's not woo-woo nonsense. It can be seen on an x-ray, right? You can lay anybody down, show an x-ray and see exactly where their femur inserts and say, why would one person assume that if the femurs are in different locations, then the knee and ankle and foot position should also then not follow suit and be in a different location? It all makes perfect sense to me. Why, though, do you think that some people have not either caught on to this? Do you think that there's such a, let's say, like the ideas that are in the industry take a long time to sort of change over, if that makes sense, right? The books have been written, and sometimes it takes 10, 15, 20 years for things to be turned over. Is that the reason why this isn't like updated information, so to speak?
I have no idea.
No.
But I would guess that you're right. That, I think, I think what it is that there is a critical mass of poor information out on the internet. And what I have found is that a lot of this information just continues to be recycled and said maybe in different ways or whatever over decades. I'm still getting people who say, I have neck pain because of a forward head. That it has nothing to do with your forward head. And so, it's just that, or I have back pain because I have a weak core. I have never strengthened core muscles to solve back pain, ever. And I don't give core strengthening muscles, because if you're using your body correctly, they will be strong naturally. And so these kinds of ideas, I think, are just circulating because that's what's out there. And so someone like me who sees things a little differently, I'm just a small voice in a large sea of voices. And so people won't find
usually
it.
What I've seen, and I've had a lot of people on my podcast, Rick, who think like you and who think like me, a little bit outside the box. And almost always they're people who are looking at the full body, right? It's so many specialists nowadays, because that's just the way people went. Everyone hyper specialized into certain areas. And I think we lost something when that happened, because because you're hyper specialized in the area, you assume that every issue has to do with the thing you know the most, rather than taking a step back and saying, you know what, I don't know. I'm not telling you that I know where this comes from. I'm just telling you that my job is to fix this, and I'm going to look at it from a more of a global, let's say, perspective. And I think that's great that you do that. And I think a lot of people who I've talked to who are dealing with pain all have that same ideology, where they say it's a little bit complex. It's psychological, it's physiological, and we're not going to just look at one area. We're going to think outside the box. And I'm glad that there are people like you who are going, above and beyond. And even maybe let's call it what it is. It's a little risky to do that, because there's going to be somebody in your industry who goes, what is this guy doing? I didn't learn anything that this guy's doing. But you're willing to do that because you know that you've helped people before, and it's worth it to you to continue to help people, even if you're risking going, quote unquote, outside the mainstream.
Yeah, well, for me, what helps is that my focus has been on solving pain. My focus isn't on helping people understand that I'm smart, or all the facts that I know, or that, whatever. So if something wasn't solving a patient's pain, then I wouldn't use it. And I would figure out how to solve that. And now that I've been doing that for 30 years, almost, I feel like, while my name may not be out there among all the giants, I feel that what I figured out is true. And that's the thing that has guided me, rather than my ego, is that if it's true, it will solve pain in all cases. And what I know does, unless there's a structural issue going on, like a tear or something.
Are there techniques or toys that you use that other people don't, or maybe you use them in ways that other people don't?
I don't use many toys. Once you understand how the body works as a system, you won't need that. But one of the techniques, though, that I have learned is hanosomatics techniques. This has been hugely powerful because it is about knocking down neurologically based tension patterns that are running through our bodies. So if you have you read Anatomy Trains by Thomas Myers?
I have not.
Okay, so Thomas Myers is a researcher in fascia, and fascia is connective tissue in the body. And it turns out that he identified superhighways of fascia that connect the head to the foot. And these occur in the back of the body, in the front of the body, the side, through spiral directions. There's upper body fascial superhighways too. And so what that is telling us is that these fascial superhighways are connecting, pieces of the body that are far away from each other. And what the Hanasomatics does is it turns out that the neurological tension patterns that are locking people in chronic pain patterns of dysfunction are typically along these fascial superhighways. And there's also a neurological component to this because these also happen to be hardwired reflex patterns that are hardwired into our bodies that we're born with. As we grow, we override these reflex patterns because we can't reflexively respond to our environment 24/7 for the rest of our lives. So our cortex overrides these so that we can just go about our day for the most part. But we never lose that hard wiring. And it turns out that hard wiring is responsible for the tension generation along these huge superhighways of patterns of fascia throughout the bodies. So I use these techniques to solve difficult pain, because usually difficult pain is due to a pattern of chronic tension and contraction rather than tightness or weakness.
From a lifestyle perspective, do you give clients advice saying simple things like, hey, you need to sit less, or you need to be worried about, let's say, your posture when you're standing in place, things of this nature, or is this not something that you're concerned with?
Oh yeah, it's definitely part of it. So posture is a big deal. In fact, posture strategy is really important when it comes to neck pain and headaches. And we can go into what that is if you want to. But what I've learned is I need to meet people where they are. And if you're sitting for 8 or 10 hours in a day in the office, then we need to teach you how to sit better and situate this office setup better, these ergonomics better, to suit your body. In my clinic, I once had a woman who came to me with chronic neck pain and back pain, and so she said, I can't work at my office anymore because it's just so painful. So we spent 15 minutes working on her ergonomics, and literally she started crying because she didn't understand that she never thought that she could sit again without pain. And it was just a simple meeting of her body and understanding what ergonomic changes needed to be made to support her body in a better way. And she was pain-free after that. It was like she felt like she was sitting in a cocoon. She was so comfortable.
For some of the listeners who know the body a little bit better, I have a lot of personal trainers and people who are fitness professionals. What are maybe some specific exercises you would give to say, let's waking up some of the glute muscles for people who are maybe in their 50s or 60s or 70s and do work 8 hours a day and happen to be sitting down in a chair?
Yeah, so the gluteal muscles, their primary function is to stabilize the hip joint and the pelvis during gait. So this is where the problem usually happens. So instead of, I'll give a glute strengthening exercise if someone, are you familiar with anterior femoral glide syndrome?
Yeah.
Okay, so if someone has anterior femoral glide syndrome, and most people with chronic hip or SI joint issues and so forth have an anterior femoral glide syndrome, the gluteal dysfunction is the source of the problem of that. And so I'll give them a specific exercise to turn on the glutes and get that to neurologically wake up and become strong again. However, if we don't fix the gait pattern, all the strengthening in the world is not going to solve anything because you're not using the muscles in the way that you're designed to use them. So what needs to happen during gait is at foot strike, the gluteals need to be turning on naturally, usually about maybe 10% or 20% of their maximum contraction. And once we get that happening, lo and behold, most pain starts to dissipate because now the femur head is tracking correctly in the hip socket and the pelvis is being controlled correctly and the rotation of the femur is being controlled correctly. And so all of a sudden, all of these pain complaints start to melt away. So we can do squats and lunges and things like that to strengthen the glutes. And certainly those will target the glutes, but they're not targeting them. That doesn't carry over into function because our knees are only bent maybe 10 to 20 degrees when we're walking. And if your glutes will only turn on when you're bending your knees 90 degrees when you're squatting, it's not going to translate to that 10 or 20 degrees when walking again. So that's what I found. All of those exercises are great, but you could have the strongest glutes in the world and they'll still turn off when you're walking. I see that all the time in athletes.
Very interesting. Makes perfect sense if you think about it. The functionality of having to do, let's say, whatever, even a more targeted exercise, like let's say like a clamshell, like a banded clamshell or something, but you're in that a severe knee bend, right? And you're forcibly pushing your leg not in the same way that you would be using it when you're walking, right? So it's a completely different direction and use of the leg and the functionality. So if the ultimate goal is to work on that gait, those other exercises, although they could help, let's say, wake the muscle up and help you know how to engage, they're still not doing what they're supposed to do. So that does make sense.
Ultimately, you have to get back to the function. How is this person using their body? How can we get them to use it better, to turn on these muscles naturally? And by the way, it's not only that muscles need to turn on, some muscles need to turn off too. And so if we look at, this is why I was interested in your adductor strain experience, is that what I have found is that when the gluteal muscles do not turn on, right, and they are, if we look at the hip joint, the gluteal muscles are a primary stabilizer of that hip joint. And so if we have anterior femoral glide syndrome, then the thigh bone in the socket starts to move like careen around in that hip joint, kind of like a washing machine that's out of balance. It's just going to start bumping up and tearing things and disrupting things, right? So, but what I found is that the less that the glute muscle is activated, the more the inner thigh muscles become activated. Because this is a cross-bracing system. I'm going to hold that up with my head. This is a cross-bracing system for the hip joint. Is the adductors on one side and the gluteals on the other. And so if the gluteals aren't working, well, how are we going to stabilize this hip joint? Well, the adductors are called on to do more work then, and they become chronically tight and disruptive as well.
Yeah. Well, that makes perfect sense to me. What are maybe, we talked a lot about the lower chain, as you called it. What are maybe some more upper chain related exercises, issues and problems that you see that you deal with differently than the average physical therapist?
Oh, sure. So let's talk about chronic neck pain and headaches for one thing. All right. So if we look at the skeleton, we'll see that the skeleton is comprised of all of these long bones, right? All these long bones here. And there's only two areas where there aren't long bones. One is the pelvis. And we all know that the pelvis is the center of function for the low back and the lower body system. The other area is the scapula. And the scapula is the center of function for the upper body system, neck and head. So what's happening is that there are significant muscular attachments running from the scapula to the neck bones and the base of the skull. So when the scapula is not working correctly, stress is transmitted via these muscles to the neck bones, causing cervical compression, side bending, and rotation in the cervical joint, especially when there's asymmetry in the upper body system, right? So no practitioner ever looks at the shoulder blade system as the source of chronic neck pain and headaches. And in my recent book, the Solving the Pain Puzzle, the one that I just published here, I have 3 stories of people who we solved their migraines and other headaches and neck pain. And it turns out that they had structural problems in their shoulder joint. Once those were fixed, all this melted away.
Very interesting.
And this goes back to our original conversation about old injuries. One of them was an ER nurse who, said, I have never had any problems. And then once she ended up having 2 full thickness rotator cuff tears in both of her shoulders, unbeknownst to her. And once I forced her to go get MRIs because something was going on with her shoulders that we couldn't identify. And I said, I thought you never had any injuries before. And she said, well, now that you mention it, 15 years ago, my shoulders hurt for a few weeks, but then it went away. And that must have been when she tore her rotator cuff muscles.
Very interesting. And you're not saying just because, let's say, I know there's like like C6, C7, like innervates down near the scapula, like the rhomboids and stuff, so you can feel pain sort of reverberate around. You're not saying like compression in that area is going to cause like a scapular pain. You're saying actual scapular and shoulder dysfunction is the root cause that causes all of the rest of everything else sort of up the chain.
Correct. Yeah. In fact, I just saw another patient with radicular symptoms, neural symptoms down into his hands. He had a herniated disc in his neck, right? We solved it in about 2 weeks. And what it was a shoulder blade. So the shoulder blade is what is likely causing all the structural problems in the neck, like that herniated disc, that then causes the radicular symptoms down the leg, down the arm. So in medicine, we see these nerve roots coming out of the neck and say, oh, it's got to be a problem with the neck. True, it is a problem with the neck. But why is it a problem with the neck? It's a problem with the neck because of the shoulder blade system that's operating on it. And, the 3 patients that I mentioned with neck pain in the book, they asked their orthopedic surgeons and neurosurgeons if the shoulder has anything to do with any of these radicular symptoms and headaches. All of them, to a person, said no, impossible. There's no research to support this. There is research to support it, but they're not looking at that research. They're looking at their own research to support their own belief systems.
Yeah, and maybe I shouldn't be saying this on camera, but I can tell you this just happened this morning. My wife had a patient, she's a pediatric sports medicine doctor, who had fractured his scapula. She's never dealt with it before. Her 2 pediatric orthopedic surgeons had never dealt with a fractured scapula before. They called the trauma surgeon who never dealt with the fractured scapula before. So they had nobody to hand this kid off to. Right, because it's just not something that they deal with on a regular basis, and if you take that down the chain, if that's not something they deal with on a regular basis, then all of the other things that potentially come from the root cause of this issue, then they're not used to it. So it does make sense, and like we just discussed, most people, including myself, always thought, okay, this was a secondary issue coming from somewhere else, right? This is a neck issue causing the scapular pain or the scapular shoulder issue, Whereas when you look at it from your perspective, it does kind of make sense. And I think, again, I don't envy you. Playing anatomical sleuth is really difficult to do, right? It's easy to ask someone where all their pain is. It's easy maybe to even diagnose and look at what's going on and is dysfunctional. But it's hard to say what is causing what. But I like how you think outside of the box and say, well, if maybe the reason why there is so much chronic pain is because we've been sort of misdiagnosing the root causes of a lot of this.
Absolutely. And Steve, I say this, in all honesty, there's no reason you can't know this information too. It doesn't require someone like me only to know that. I've trained all of my therapists to know this. I've trained other personal trainers to know this. So anyone can be trained, yoga instructors, Pilates instructors, anyone can be trained to know this. You just have to have the desire, really. And so the sleuthing, it's funny that you mentioned that. You've said that twice. In the introduction to my new book, Sherlock Holmes is one of my heroes, right? And the introduction is about Sherlock Holmes and how he is a great sleuth. And so that's how I use these and one of the reasons he's a great sleuth is because he realizes that everything matters. Every little detail matters. But the problem is we have not been trained to understand how those details matter. And that's what I've been figuring out for these last two plus decades now. And the more I understand it, the simpler it all becomes. And so that's why when, people look at me like, oh gosh, this guy knows everything. No, it's so simple. I don't know everything, but I know enough to help a lot of people with chronic pain. And so it's not impossible to learn this and understand it. It's so much simpler. And that's invariably from the patients whose chronic pain we solve at my clinic, they're all just like, I can't believe it was that easy. Why isn't everyone else doing this? And that's like that. That's the recurring theme because it is so easy.
Well, Occam's razor, as they say, sometimes the simplest answer is the best answer. Rick, this was super enlightening and fun. I hope maybe we can do it again down the road, talking about some other topic, maybe even hone in on one particular, let's say, issue or element and go down the anatomics of it. But why don't you give my listeners some insights into where they can find you if they're, let's say, personal trainers or people in the health and fitness realm and they want to learn more about what you do, or if they're maybe general population and have problems?
Yeah, I think just go to my website, rickolderman.com, and that's older man, opposite of younger woman. And just go to rickolderman.com and you'll see all my products. I have some free stuff on there. But that's where you'll find everything. That's the easiest way to dive in.
I will put all the links in the description. My guest today has been Rick Olderman. Thank you for joining the TrulyFit Podcast.
Thank you, Steve.